just after 8, and I'm excited to have Dr. Sadiya Khan from Northwestern University, Northwestern School of Medicine, Feinberg School of Medicine, talk to us about a heart failure with the preserved ejection fraction, or HFpEF, as I think it is called. Dr. Khan is a cardiologist. She's an assistant professor, and she's also the associate program director of the cardiology fellowship at Northwestern. She's got many NIH grants, over 200 publications. She's an associate editor at JAMA Cardiology and the European Journal of Preventive Cardiology, and she's also a vice chair of the American Heart Association Publications Committee. So without further ado, I'll let Dr. Khan take it from here. Thank you.
Thank you so much for that kind introduction and for the invitation to join you all virtually. It's really a pleasure to be able to spend some time this morning discussing heart failure with preserved ejection fraction. Where are we in 2022? And happy to take questions as we go or at the end. So because Swapnil and I know each other from social media, I'm going to start with a social media meme. I'm sure many of you know this, how it started, how it's going kind of idea. So for heart failure, of course, dropsy or generalized edema has been observed or written about since the ancient Roman and Greek times. And somewhere in the 15th and 16th century, people started using bloodletting to treat heart failure. Well, we've come quite a long way in terms of pills, devices, advanced mechanical support, but really these remarkable advances have come for treatment of HFrEF, or reduced ejection fraction with systolic dysfunction. And treatment and prognosis for patients with HFpEF remains quite limited in 2022. So we're going to spend the next 35 to 40 minutes talking a little bit about where are we today and where are we going. So we'll do this by covering the following objectives. We'll review the evolving epidemiology of cardiovascular disease in the United States with a shift towards heart failure and HFpEF. We'll define HFpEF. What is it really? What are therapies or GDMT for HFpEF and management of associated comorbidities? We'll discuss a precision medicine framework for molecular subtypes of HFpEF and how we can approach targeted treatments. And we'll conclude with emerging risk-based strategies to shift upstream towards a prevention focus for HFpEF, which will be especially critical among people living with renal insufficiency and end-stage renal disease. So to get started, we'll do a little bit of a history lesson. And many of you are familiar with kind of this, the Spanish flu is this big spike here, and heart disease starting to climb in the 20s and 30s as the leading cause of death. And Paul Dudley White, who's a very famous cardiologist at the time, said, we know the hypertension may be an important compensatory mechanism, which should not be tampered with, even if it were certain that we could control it. So really remarkable, right? If you think about how we manage hypertension now, trying to debate blood pressure lowering goals, it was thought that we shouldn't even touch it, even if we could. It wasn't until the Framingham Heart Study started in 1948 and really that first seminal paper from Bill Cannell and the group that coined the term risk factors that you start to see this decline in heart disease mortality over the next several decades. And in fact, NIH put together the Bethesda Conference in 1978 really to better understand if the decline that was being observed was an artifact or whether there was an understanding of what had contributed to this decline in terms of improved risk factor control, better blood pressure levels, use of secondary prevention and treatments, and how we could then amplify those things. Unfortunately, in the past 2 decades, we've been monitoring cardiovascular disease mortality, and in 2011, a plateau was observed. So while there was continued decline that we had seen in the past several decades, this started to change, and all of a sudden you see this flattening. And we were fortunate to be part of an updated NIH conference called Bethesda Plus 40, which celebrated the 40th year anniversary of the 1978 conference, to start talking a little bit about why this plateau may have occurred. In addition to the plateau, the other thing that's striking in this graph that's demonstrating age-adjusted mortality rates are the persistent disparities with higher mortality rates for non-Hispanic Black individuals compared with non-Hispanic white individuals that really hasn't narrowed over time. So one thing we thought to look at was, what about the different types of cardiovascular disease? So if we pull out ischemic heart disease, where we've made the most progress, we have all the new interventions and therapies and treatments. Well, it's a little bit of a different story. There's continuing decline. In contrast, if we look at age-adjusted mortality rates for heart failure, they're increasing, and that inflection point occurs in 2011. So it seems like some of the progress that we've made is now being offset by increasing mortality rates in heart failure. If we look at the overall number of heart failure deaths and compare it with other leading causes of death like heart disease, cancer, chronic lower respiratory disease, heart failure, when mentioned on a death certificate, accounts for over 200,000 deaths, and this is pre-COVID from 2019, so we can really interpret these numbers. While heart disease continues to be the leading cause of death, we know that there have been challenges with interpretation of these causes of death. In addition, our observational epidemiology data suggests that the subtype of heart failure is also changing, which may correspond with some of the increases in mortality that we're seeing, where we're shifting from a HFrEF predominant heart failure group to one of HFpEF. And these are data from the Atherosclerosis Risk in Communities, or ERIC study, that show in race and sex groups overall in community dwelling adults in the US in multiple cities, incidence or first hospitalization for heart failure, that black line, is increasing in every single race and sex subgroup. But if you look at where the trend is increasing the most, it's for HFpEF in the blue line, and the greatest increases are occurring for Black women. Now, we wanted to take a look a little bit at our own data to see kind of how prevalent is HFpEF among people being hospitalized at our institution. And one of the things that struck me was not only in the 65 and older are about 3/4 of our patients HFpEF, but even in the younger adults, where we don't typically think of HFpEF being the leading cause of heart failure, we are seeing a lot of HFpEF, which suggests that we're going to continue to see this condition and need to have a better understanding of how to approach it, diagnose it, and manage it. So we also know why this might be happening. It's not surprising, I'm sure, to anyone that risk of HFpEF is increasing because the risk factors are increasing, or control is worsening. Rates of obesity are increasing. Control of hypertension is worse. Rates of prediabetes and diabetes are increasing. And these are probably all the same reasons that renal insufficiency is worsening as well. So I've convinced you that HFpEF is important. How do we define it? How do we treat it? What should we do today? So one of the biggest challenges in heart failure, before we even get into whether or not we should use ejection fraction to classify, has been the lack of a clear or universal definition. Different societies had different criteria for how heart failure was diagnosed. And so in 2021, the Heart Failure Society of America, the European Society of Cardiology, came together and put a writing committee together to really define the stages of heart failure with clear details on how we would define what signs and symptoms of heart failure meant. Of course, we all understand signs and symptoms of congestion, but they're so subjective, and it can be so hard to understand whether something is cardiac or non-cardiac dyspnea. And so the added benefit of this document was that there was a requirement for objective documentation of structural and or functional cardiac abnormality or evidence of congestion, whether by BNP, by echo, or by invasive hemodynamics. I think that was really critical to be able to start to create some harmonization across studies, across trials, and in clinics. The second thing that the document did was create different classifications based on ejection fraction. Now, I'm open to debate about whether or not this is helpful or more confusing, because it's adding even more categories. But the idea was to not just have a single point in time classification, but create further categories to distinguish between reduced ejection fraction as those that are truly less than or equal to 40%, those in that mid-range, 41 to 49, who might be getting there because they're coming back up, they're improving, or they might be getting there because they're declining, and HFpEF, which was defined as an EF greater than or equal to 50%. I think the serial assessment and reclassification is also important because we know that EF is dynamic, that people can decline, or improve. I don't know if someone is trying to ask a question or can go on mute, please. The other thing that the classification did was also create classification based on symptoms. So we've always used ejection fraction, and staging systems have been based on symptoms, but it's really important to distinguish those who are new onset or de novo heart failure, those who have persistent or worsening heart failure, or in the green, the resolution of symptoms. While heart failure can't be cured, we do know that our goal is to try to prioritize being able to get someone symptom-free. So that was really a culmination of trying to put together a new definition, and there had been many documents leading up to it to try to better clarify why we needed it. And I love showing this Venn diagram because these are trials that we'll talk a little bit about, including TopCat and Paragon, but also Relax and Preserve, that are trials of HFpEF. And if you look at how much the criteria overlap across these different trials, they don't, right? And this is starting to be, if even in rigorous RCT studies we're not having great overlap, well, I think it's even more challenging in your day-to-day when you're managing individual patients. So one of the documents led by Jen Ho, who's at BI and has done really great work in this area, was to try to provide an outline of how you can approach diagnosis in a patient that's suspected with HFpEF. And the first is really the physical exam if somebody has congestion at rest or has laboratory findings of congestion. The next phase is evaluating exercise intolerance, and our armamentarium for diagnostic tools, which includes CPET, 6-minute walk, invasive hemodynamics, which are included in the advanced testing, are really important to be able to understand if there is objective evidence supporting increased LV filling pressures. The other thing that's important about this diagram are these secondary HFpEF conditions that we'll talk a little more about, but I do think there can be a lot of overlap between someone who has valvular disease or pericardial disease, right-sided heart failure, primary cardiomyopathy like hypertrophic cardiomyopathy, which of course can overlap with someone who might have hypertensive heart disease, high output state, and other states of edema like in kidney dysfunction or liver dysfunction. So we talked a little bit about invasive hemodynamics, and I think the other thing that's really striking, and it took me several years of seeing patients, that it still surprises me that in patients who have no symptoms at rest, when exerting themselves, have very significant impairment in functional capacity and get extremely short of breath. So what's the physiology behind that? This is a really neat study by Barry Borlaug's team at Mayo. And what they did was they wanted to specifically target that group of people that had unexplained dyspnea with exertion. They had normal NT-proBNP levels and a normal wedge at rest. So they did not have elevated filling pressures on invasive assessment, but you can see how these two curves separate when exercising in a recumbent position. And you see this dramatic increase within a minute of the wedge. And I think that is really visually striking when oftentimes patients are told, well, you're probably just deconditioned, or maybe something else is going on, or you should just keep walking through it. But this is, physiologically exactly what that dyspnea comes from. Now, it can be really challenging to assess or confirm that without invasive testing, which is not always available or widespread. So what else can we do? Barry's team also took a look and said, well, we have a lot of patients where we've done these invasive hemodynamics. Could we develop a non-invasive score that has reasonably good predictive accuracy to help in the clinical setting? And so in this study, they looked and derived in 414 patients who had come in with unexplained dyspnea and validated in about 100, and this has now been validated in other HFpEF cohorts and studies, and said, let's create a simple scoring algorithm of data that will be available to any clinician that's seeing a patient that includes BMI, use of antihypertensive medication, paroxysmal or persistent AFib, PASP from Doppler echo, age, and E over E prime, and created this HFpEF score. And then based on the points from 0 to 9, you can see that a score of 4 or 5 gets you about 70 to 80% of the way there, and higher is even more likely to have HFpEF. Now, this is not diagnostic, but gives you a little bit of a screening probability to say, I'm more suspicious that this may be HFpEF in a patient. the other exciting thing this year was that ACCHA and HFSA put forward new guidelines that finally, for the first time, had true guideline-directed medical therapy for HFpEF that incorporated cardiac and non-cardiac medications and discussed both myocardial targeting as well as comorbidities to improve the quality of life and survival of patients living with heart failure. Now, another ode to social media, anyone who follows Greg Fonarow knows that he will never get tired of tweeting GDMT works and showing the pillars of heart failure, of HFrEF and quadruple therapy, which is amazing. And I think this slide says it all in terms of the relative risk reduction for each additive therapy, as well as the 2-year mortality for initiating all 4 at once. So great data, great evidence. I'm so jealous of HFrEF, but I think we're getting there, and I think we've got some exciting data to talk about. So for HFpEF, in this year's guidelines, there were several recommendations for what we can call GDMT. That best level of evidence, or the highest class of recommendation of 1 was focused on hypertension and making sure that medication titration to attain blood pressure targets for less than 130 were achieved. In addition, SGLT2 inhibitors were included, beneficial for decreasing heart failure hospitalization and cardiovascular mortality. This should now be upgraded, but of course this was published before some of the trials we'll talk about today. In patients with HFpEF, management of AFib can be very useful and important to improve symptoms, so thinking about comorbidities as well. The class of recommendation 2B for MRAs comes from the fact that the overall trial in TopCat was not positive, although we'll talk a little bit about why that may have been, but should be considered to decrease hospitalization. I think this is something that could be even stronger, and we can debate whether or not that's the case, but especially in patients that are congested, where we know that having an MRA on board with a loop may be beneficial. In selected patients with HFpEF, the use of ARBs can be considered, and in selected patients, ARNIs. So where did the data come from for these recommendations? So TopCat, of course, is one of the first and largest studies for HFpEF, and the primary outcome here, the hazard ratio was 0.89, but crossed 1, and so was not significantly different between placebo and spironolactone. For the outcome of hospitalization for heart failure, that outcome did achieve significance. But if you look at the TopCat data, and this has now been done in several different ways, but separate out those patients that were enrolled in the Americas compared with Russia and Georgia. And even if you don't look at who's on spironolactone or who's on placebo, you can tell that those are 2 very different groups of patients. And they also looked at whether or not the potassium changed in the people who were supposed to be on spironolactone in Russia and Georgia. And it really didn't, which just doesn't make sense. And more importantly, the hazard ratio for the subgroup in the Americas was significantly different for the primary outcome, in addition to hospitalization for heart failure. So I think the evidence is stronger, and I understand the guideline committee is tied to the primary design of the trial and the primary outcome. But I think in day-to-day clinical practice, in patients who would benefit from MRAs, we do have good data that it can reduce hospitalizations and perhaps may improve the mortality as well. In terms of ARNI being the next therapy, sacubitril valsartan, the Paragon study was another disappointing study where the primary outcome for heart failure and death from cardiovascular causes in patients with HFpEF was not significant. Neither was total hospitalizations for heart failure. But the subgroup analyses were important, and they were very interesting. In those who were female, there was a benefit. And this may have to do with postmenopausal really reduction in neprilysin inhibition. So biologic plausibility for having a sex-specific difference, as well as an LVF at or below the median. And we talked a little bit about these confusing classifications of mildly reduced and these in-between groups. But it's important to note that at or below the median was 57%. So there really may be benefit in a subgroup of HFpEF, maybe not in a hypercontractile HFpEF, but in others who have HFpEF. Of course, no talk is complete without mentioning SGLT2 inhibitors, and really have been, I think, altering the trajectory and course for HFpEF. This was the first therapy that showed a benefit in the primary endpoint. Shown here are data from Emperor Preserved that led to the FDA approval, and showing the significant difference between placebo and EMPA-10 in patients with HFpEF. The second study was a smaller study looking at DAPA. Preserved HFpEF was an investigator-initiated study that was led by Mikhail Kazabord, and really focused on understanding the mechanism in a short time frame, and demonstrated that there was a significant improvement in symptoms over 12 weeks. Even in the Emperor Preserved study, I think it's important to note how quickly these curves separate when an SGLT2 inhibitor is started, which of course we could have a whole different session about talking about why that might be and the different benefits in the short term versus long term. So this study, the Emperor Preserved study, led to the FDA approval earlier this year for HFpEF. One of the challenges continues to be in the states, of course, of coverage and copays, but I think remarkably it advanced our treatment and options for being able to finally say we have a treatment that improves outcomes. Fast forward a little bit, the DELIVER study that was just published about 2 months ago now, that looked at patients with HFpEF as well with DAPA, showed a remarkably consistent benefit in the primary outcome that included worsening heart failure and death from cardiovascular events. Of course, it does look like this is driven by worsening heart failure with no significant difference in death from cardiovascular causes or death from any causes, which is an important point in this population that has a significantly high event rate. And so I think the other thing that's important, as exciting as it is to see the consistent benefit of an SGLT2 inhibitor, even those people in the SGLT2 inhibitor arm have a very high cumulative incidence rate over the course of really just 2 years, where 15 to 20% of people are having an event. So that's a remarkably high residual risk as well. So I think there's enthusiasm and excitement, but there's a lot of work left. The subgroup analysis here is really consistent no matter how you slice or dice or look at the different subgroups in terms of age, sex. Race and ethnicity, of course, is a little problematic because there weren't a lot of non-white individuals enrolled. But by symptom burden, EF, classification, NT-proBNP, diabetes status, AFib. So I think really remarkable in terms of the consistent benefit across the subgroups. The last component of the guidelines that I think is really great was this focus on comorbidity and chronic disease management. To say, we know that we've always focused on treatments for heart failure in the heart failure guidelines, but our patients are affected by so many chronic diseases that make them more likely to get heart failure, but also impair their quality of life. And so focusing on those is really an important part of comprehensive care, including hypertension, diabetes, coronary artery disease, valvular heart disease, atrial fibrillation. In addition, other non-cardiovascular conditions like iron deficiency, where there's data in HFrEF for iron replacement, in terms of rhythm control strategy with AFib, CPAP for sleep apnea, and in terms of preventive therapy for cancer-related cardiomyopathy. Now, I think this is great that we're starting to pay attention to it, but unfortunately, we haven't been doing very well in the States in terms of blood pressure control and diabetes control. So these two come from the NHANES survey, which is a cross-sectional survey that is representative of the US general population. And in those people who reported heart failure, so we don't know if it's HFpEF or HFrEF, but presumably half and half, because that's what our general epi is at this time, only about 50% had their blood pressure controlled in the latest cycle, which may be worse now with COVID. And similarly, only about 50% had their diabetes controlled at a goal of 8%. So these are low-hanging fruit in terms of that high residual risk that we just talked about in these patients, and things that need to focus on at a population level, at a society level, as well as what implementation strategies may be needed. So I'll bring back GDMT works for HFrEF, and I think it works for HFpEF too, and we're really starting to develop this armamentarium and comprehensive approach, and I think we have to be broader about the comorbidities as part of our GDMT. So we showed the data for ARNI and MRA, really predominantly for reducing heart failure hospitalization, so I don't want to overstate their mortality benefit. The combined outcome for SGLT2 inhibitor, but also the importance of treating comorbidities, hypertension management, CAD, AFib. We didn't talk about weight loss and management, but really important with tirzepatide and new therapies like Ozempic that could really transform people's quality of life. Exercise strength training, the Rehab HF study, really great. I think starting to invest in non-pharmaceutical therapies that can improve quality of life as well. I think it's important to note that beta blockers are not included in this. And in fact, some data, retrospective data, not randomized controlled trial data, have demonstrated that there could be harm from beta blockers, particularly in subgroups of HFpEF where they're more restrictive phenotypes, that lowering that heart rate could actually reduce exertional capacity. So I think this is starting to be an algorithm that we can think about. So I love this title by Dr. Braunwald in Braunwald's Corner, Heart Failure with Preserved Ejection Fraction, a Stepchild No More. And really that's over the course of 40 years from when this paper by Eric Topol was published in 1985, really describing this hypertensive HFpEF phenotype where patients presented with dyspnea or chest pain and had extremely small cavities and concentric LVH. So what are the things moving forward and how can we really start to refine our approach to HFpEF and how we treat it? So one of the challenges is that we have so many different classification schemes. We use ejection fraction, we use symptoms and NYHA class, we use stages and A through D. And given that heart failure is a syndrome and not one disease, how do we integrate these various categorization schemes? And I would argue that perhaps we could develop more precision about the molecular subtypes and target treatment. So we're not trying to treat 6 different diseases, but try to identify what disease someone has and then treat that. So these are echocardiograms from 4 patients with HFpEF that are part of a primer in JAMA Cardiology a couple of years ago that show 4 very different phenotypes of HFpEF. You can see this one has, if this is the left ventricle here, this one has a ton of hypertrophy, this one has more atrial dilation. And so we see significant differences in the echo phenotypes, but they all have HFpEF. And if we look at strain, which is a measure of systolic function, we see very different patterns as well. The darker red is the better, so the more negative the number, the higher the function. And you kind of see in this one, there's this area that's really dark red, but everything else is not great. In this area, this just middle part isn't that great, and everything else is really red. And so these different patterns can give us some insight as well to start to think, well, these are different diseases. And really what it comes down to is that these are different types of HFpEF that probably need different treatment, whether it's TTR amyloid and now with tafamidis and targeted therapy for HCM, similarly mavacamten, and we'll talk a little bit about the Explorer study, if it's a restrictive cardiomyopathy or a genetic Fabry's disease. So really starting to peel away at the onion of what is the condition or the disease and not the syndrome that we're treating. So I think one of the analogies that I've found useful has been this idea that heart failure or HFpEF is this umbrella term. And what we're really trying to better understand are the phenotypes and the endotypes. And I love using cardiac amyloid as an example because I think it's one where we've actually made it. We understand that there is a different phenotype of people who present with cardiac amyloid. It's not as rare as we once thought. And those that have a variant in TTR have a targeted therapy, or if they have wild type TTR with tafamidis. There are probably other phenotypes that are similar to this, some that we know, some that we are still trying to better understand. And there may be clues, and in the guidelines, they started to outline specific questions to ask the patient or the family member with phenotypic findings and really start to better understand, is there a heritable component to this? Is there a rare variant cardiomyopathy that may be contributing to this? Or can we start to understand if there's other testing that needs to be done, specifically with cardiac morphology, if there's marked LV hypertrophy, LV compaction, RV thinning, thinking about hypertrophic cardiomyopathy, LV non-compaction cardiomyopathy, or ARVC. If there's abnormally high or low voltage or conduction abnormalities, repolarization abnormalities in terms of arrhythmias, if there's NSVT or PVCs or VT, VF, early onset AFib or conduction diseases, these may all point to a heritable component of HFpEF. And of course, we know that heart failure is heritable, but we don't know how much of that is due to monogenic or Mendelian inheritance versus largely polygenic. But there may be more cases than we know that are due to a specific variant change. So has anyone looked at that? Of course, someone has, and this was a retrospective study that was done in the CHARM and Corona clinical trials, which included heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Surprisingly, they were largely people who had heart failure with ischemic heart disease, and so I think that's even more interesting to see some of these rare variant changes that were identified. There was also a lot of overlap based on ejection fraction, which starts to tell you that maybe ejection fraction is not the greatest way to characterize people. And so the people in this large circle with heart failure with reduced ejection fraction had variants in all of these genes, as well as the ones on the inner circle that overlapped with HFpEF. And then heart failure with mid-range ejection fraction had slightly fewer hits, but also overlapped largely with heart failure with reduced ejection fraction and preserved ejection fraction. The other thing that I think is important is TTR amyloid is picked up here. So we know that there are cases of TTR amyloid that are likely getting missed among people diagnosed with HFpEF, but also that there are other phenotypes like ARVC, hypertrophic cardiomyopathy, inflammatory cardiomyopathy, FLIN-C, and arrhythmias. So it starts to tell you that our idea of a genotype change causing a phenotype is also not probably correct, and one variant genotype change can lead to many different phenotypes. And so starting to better understand what the culprit change is may help us start to target the right therapies. The other thing that there's significant overlap with is early onset atrial fibrillation. And the more we learn about AFib, the more we realize that it may be a HFpEF precursor and the first manifestation of someone who is at high risk of developing HFpEF. And turns out the same genes, these cardiomyopathy genes, are relatively enriched in people who have AFib, and early onset AFib has been defined in several studies as those individuals who develop AFib before the age of 66. But you can see there's a bit of an age-dependent curve in terms of the prevalence of variants by age. So those who are less than 30 had over 15% of these rare variants in cardiomyopathy genes. And in that 30 to 59 range, we see about 10%, and then it starts to drop off, which again tells you that, of course, AFib is a disease of aging, and as people have hypertension and obesity and diabetes and have other hits, if you think about the second hit model, they are more and more prone to developing atrial fibrillation. But genetic risk may be another one of those hits or risk factors as well, and identify people that are predisposed to AFib as their first manifestation of a cardiomyopathy or heart failure. The genes were very diverse in terms of what were identified as well, and of course, Titin is always the most common gene that is picked up in these. So why is it important to look for these gene changes? I think it's as hard as it is to diagnose HFpEF, it's I think even harder to diagnose hypertrophic cardiomyopathy sometimes and or distinguish it from HFpEF. How many times have you seen someone who has hypertension and of course could just have hypertensive heart disease versus do they have hypertrophic cardiomyopathy? And some of that, as we do more and more genetic testing in individuals, I think needs to be broadened to say it's not just if they have hypertrophic or LVH without hypertension, but of course, as more and more people are developing hypertension or have hypertension, they may have both hits, and that might be why they're presenting earlier or younger, or it may be another risk factor for them. And why it's important is because we finally have a therapy that targets people with hypertrophic cardiomyopathy. So the Explorer HCM study looked at mavacamten, which is a cardiac muscle hypercontractile agent, and specifically looked at symptoms and outcomes in terms of physical functioning and their LVOT gradient. And you can see their post-exercise gradient is significantly better for those on mavacamten, as well as their resting gradient, as well as their biomarker levels, and their ability to walk was also better, and there's overall symptoms. So this is the mavacamten group, and you see more and more people, up to 50% of people ended up in NYHA functional class 1 at the end of this study. And based on this study, the FDA approved mavacamten for patients with obstructive hypertrophic cardiomyopathy, which I think pushes us even more to try to distinguish people who have HFpEF from hypertrophic cardiomyopathy, as well as the implications for family testing, cascade screening, and other things that we can do in terms of treatment and management. The other condition that the guidelines called out specifically is amyloid, because we have a targeted therapy with tafamidis. And this, again, is based on clinical evaluation, imaging, if there is a suspicion for cardiac amyloidosis. And I've highlighted here this emerging data that has been picked up, that individuals who have carpal tunnel release surgery or have carpal tunnel syndrome are much more likely in the next 10 to 15 years to develop amyloid, because it may be their first manifestation based on the fibrils that develop in the wrist. And so it's always a good history question if there's uncertainty or suspicion as well. As the diagram identifies, it's really important to understand whether or not someone has, what type of amyloid someone has, as once amyloid is suspected, and the different evaluation that can be done, including PYP scans, which are helpful for TTR amyloid. Distinguishing between a genetic variant as well as wild type can be really important. And I think one of the most important things about amyloid is we know that the most common variant, TTR valine 122 isoleucine change, is enriched in people of African ancestry, where their population prevalence is about 4%. And as you can see, these curves separating, this is data from the regards cohort, there's a much higher risk of developing heart failure. Now that risk is really in 70s, 80s, 90s, later in life, but still for something that we know we have a treatment for, if identified, and can sometimes be challenging to get the right diagnosis, I think is also important to better understand the genetic contributions. So future directions, we're really excited that HeartShare, which is our HFpEF cohort that is just getting started in the States, is starting to ask and address some of these questions. We're putting together a new cohort of HFpEF, and we're one of the sites, and the other sites, including Mass General, Mayo, Penn, UC Davis, and Wake Forest, are going to be all working together. So really excited to be able to answer some more of these questions that we've posed in terms of how we can better classify HFpEF to be able to better treat them. So the last thing is a little bit less about HFpEF and a little more where my heart lies in terms of prevention, and thinking about if there's so much trouble and so much risk once someone has symptoms and we can't cure it, let's start earlier. And I think this is another great Braunwald's Corner, how to live to 100 before developing clinical coronary disease. This is his suggestion. My suggestion is that we also want to live to 100 without heart failure. And so we may want to add blood pressure burden or cumulative blood pressure and optimizing that. But really, this applies for all of cardiovascular health metrics and trying to optimize and maintain them across the life course. So we talked a lot about the growing burden of HFpEF, but it's really the tip of the iceberg if you think about on a population level where we're going to have the most impact. And if we shift our focus to the broader at-risk population for prevention of heart failure, how can we better do this to target those who are at risk? So the other great part of the new guidelines was there was a new section on prevention with terminology of at-risk and pre-heart failure for stage A and B, where lifestyle modification and prevention is needed. They're similar to the 2017 guidelines. There was a class of recommendation 2A level of evidence B recommendation for natriuretic peptide biomarker-based screening. And this was really based on the STOP-HF and the Pontiac study, both that used BNP and NT-proBNP for screening people who do not have heart failure. I think this is something that we've talked a lot about in patients with renal insufficiency who already have elevated biomarker levels. Should we be starting to screen them and monitor for if there's increases that are happening that could be suggestions that someone is more compromised from a myocardial standpoint in addition to their renal insufficiency? One of our biggest challenges is CMS does not reimburse for NP screening without symptoms, so this hasn't really had widespread implementation in the States. The second new recommendation was about multivariable risk scores to predict incident heart failure and starting to use absolute risk assessment in addition to biomarker-based screening, where I think we'll have a little more success. And one of the risk tools that was included in the guidelines is the pooled cohort equations to prevent heart failure, or PCP-HF, which was one of the models that we've worked on using cohort data from Eric Mesa Framingham Cardiovascular Health Study in Cardia. And shown here are all the risk factors that are included in the derivation and validation, and work led by Dr. Rupal Mehta incorporated UACR and EGFR, working in CRIC to really make sure that we're accounting for the higher risk in patients with renal insufficiency in this calculator. So what do we do with risk? Of course, it all comes back to SGLT2 inhibitors because the only thing that matters are flozins. But this is an older meta-analysis, but I really like this table because it stratifies by history of heart failure, and it includes those people with a history of heart failure and looks at the benefit and those without a history of heart failure. And it's surprisingly consistent. So that means the prevention of that incident hospitalization event is just as good as prevention of recurrent events. So I think that really starts to set the stage for primary prevention of heart failure with flozins. We're there for HFrEF, we're there for HFpEF, and I think we still need to get a little bit closer to be able to do this. So to try to build on this, we published a viewpoint in JAMA Cardiology, really trying to make the case that while we've got some data for stage C now, we need to move upstream to stage A and B and start to think of flozins like statins. And this was also another Braunwald's corner that reinforced our idea that SGLT2 inhibitors are the statins of the 21st century. So I'll come back to Greg's outline and say, I think we can also define pillars of GDMT for HFpEF prevention, because we have good data that SGLT2 inhibitors, thiazides, ACE, ARBs are very beneficial. There's ongoing studies of MRAs, but I think it's another class where there could be much benefit in the prevention side before someone develops signs and symptoms. So I think coming back to our how it started, how it's going meme and leave some time for questions, I think we can go from failure to heart and kidney success for all with this outline. Concluding remarks. So we talked about the changing epidemiology of cardiovascular disease, and one that's really shifting from ASCVD that we've figured out how to treat, although not always doing optimally, to one of heart failure and HFpEF that we don't have as many great treatments for. GDMT works in HFpEF, but may be limited by the heterogeneity of the groups that we're applying it to. And so identifying molecular subtypes and then targeting people with the type of therapy that they need, whether it's tafamidis or mavacamten, or hopefully more and more as we develop them, as well as remembering the comorbidity-specific treatment. And lastly, guideline recommended pillars of heart failure prevention with optimal implementation once an at-risk group is identified, I think can really have great potential on a public health scale. So thank you so much, and happy to take questions.
Thank you, Sadiya, for that wonderful, marvelous overview of the topic. And if anyone has any questions, please raise their hand and unmute yourself. But while people are thinking up of things to ask, I'll start the ball rolling. Especially in patients that I see with chronic kidney disease, it's not at all uncommon to have signs of congestion. I personally have not ordered a BNP, and I kind of wonder if there is any data on underdiagnosis, and should we be doing an echo in all our patients who have chronic kidney disease with these kind of symptoms, which are not uncommon?
Yeah, I think the easy answer is it would be yes, of course. But the hard answer is the congestion from their kidney disease, or just because the echo shows structural abnormalities, which are incredibly common that we know from cohort studies, or like you say, their biomarkers are probably elevated, again, because of course they're congested. The distinction is, do they have elevated LV filling pressures? And I don't know. And so the echo can be helpful with that. I don't think everybody who has kidney disease has elevated LV filling pressures, but that's what we want to understand is for those people that do, then they also probably have subclinical heart failure. And is there more that we should be doing? The other thing with the biomarker screening that I think can be helpful is that the trajectory can be really important. And so even if it's elevated at baseline, if that's really where their baseline is when their filling pressures are about euvolemic, when they have a bump, then it helps with interpretability as well. But I think we should do a STOP HF study for chronic kidney disease and figure out what that criteria would be for enriching the population for prevention.
Absolutely. And on that same note, some people would say, what does it matter? We mostly give these patients Flozins anyways. We should be, though we don't always target intensive blood pressure lowering. But perhaps, I don't know about my colleagues. I have personally not prescribed an ARNI. We usually leave them on an ACE or an ARB. But, that plus perhaps, we'll be more diligent in trying to get them on an MRA. Is that something you think we should be doing more diligently? And maybe that's how the echo might be useful.
Yeah, I showed you the data that even when someone has HFpEF, we're not being that diligent. So I don't know that that's really something that you need to criticize yourself on. But I think the challenge is until we know what we're treating, we're still trying to figure out why would treatment be different or how could treatment be different, and better classifying whether or not there is diastolic dysfunction or left atrial enlargement. Then is there risk for AFib? Is there other things that should be going on? I do think that information is important, but I agree with you, largely wouldn't change the management right now. But as we learn more about the different phenotypes of heart failure or of LV remodeling in patients with chronic kidney disease, I think we need to be doing more of that to have a little more precision in what we're doing.
And along those lines of what you were saying about the umbrella, is it possible that, there are these heterogeneous conditions which encompass HFpEF? And could that be a possibility? Is that why the big, large trials have not been, as dramatically positive? Yes, Flozins showed a signal in both the two trials. They work in, anyone almost. But the other trials have, they have tantalizingly close, but not, not shown the signal that we would have wanted to. Is there any move towards trying to identify populations a little bit more precisely for future trials, or leave them under the HFpEF umbrella? Yeah.
No, I think totally. I think that is definitely where we're heading in terms of doing actually smaller trials, but more homogeneous populations. And so can we better identify if we pick a very specific type of HFpEF, what the treatment effect might be?
And I think Mark in the chat has a similar question. He's asking, why do you think we are not seeing a longer term benefit for heart outcomes even in the Flozin trials, like beyond the recurrent heart failure presentation?
Yeah, I think it's a great question. I think most people who have HFpEF have multimorbidity, right? And so the outcomes in terms of death are not driven by their heart failure. And in fact, there have been data from other trials that have shown that non-cardiovascular causes are the leading cause of death. And even among cardiovascular causes, it may not be heart failure related. And so it's hard to have any drug really influence that when it's more of a heterogeneous mix of a lot of different conditions. And I think it goes back again to how frequent that outcome is that tells you how high risk of a population this is.
Yeah, that's quite possible. The other question I had would be, again, going back to my point about having not used an ARNI, if nephrologists start using, sacubitril, valsartan, or Entresto, is there something we need to be careful about? Is there anything different for someone who is naive to using these drugs? I know they've been around for a while, but somehow the uptake seems to be much slower than, say, with Flozins.
Yeah, definitely. I think some of the challenges, kind of the washout to switch over from an ACE and an ARB to an ARNI. The second is cost. They're still pretty expensive. The only, I think, hesitation that I have is when someone has a low blood pressure. In fact, in the opposite case, when someone has resistant hypertension, they could be incredibly useful because they're great antihypertensive in addition. So I have primarily been using it in HFpEF patients with very difficult to control hypertension.
Peter Magnan.
I guess extending Swapnil's sort of clinical questions about CKD patients. Obviously, we share lots of patients with cardiologists, some of whom are great and some of whom I wonder about. And
myself,
certainly, see lots of people with worsening kidney function, no proteinuria, some for a kidney perspective, no indication for an ACE or an ARB, and with so-called HFpEF, and who are, on high dose of ARB or switch to an ARNI. And I sort of really wonder whether they're doing the right thing. Now in HFrEF, we're used to many of them being hypotensive and realizing you have to stick with the drugs anyway.
Yep.
But when I see a blood pressure of 90 systolic and somebody's feeling faint, the cardiologist still pounding the ARNI, and the kidneys are getting worse because of it, I question that. So I assume in these trials of ARBs and ARNIs in HFpEF that they're not hypotensive and maybe they're being overtreated.
Yeah, I think the challenge of the trials compared to generalizing is how rigorously they use that run-in period and to be able to make sure that someone could tolerate it before they were randomized. So I think it's always tough to know exactly when someone is symptomatic from their hypotension and whether or not the drug is the right choice. But I generally will avoid it in people who have lower blood pressures, because the data aren't that great for ARNI for HFpEF, right? There's potential benefit, and they're, especially in my patients who are very symptomatic, they're refractory to other therapies, they're on their Flozin, they're on their MRA, and they have remarkable ongoing congestion, then it's potentially useful. Or they have really bad hypertension, and that's what gets them symptomatic. So I think it's finding the right patients and not necessarily widespread use, because there are harms.
Yeah, that's what I guess Peter was alluding to, yeah. On the other hand, you don't want necessarily to react to every bump in creatinine. We are okay with the creatinine going up as long as the patient.
I just call a nephrologist.
Yeah, we do get those consults. The creatinine bump is fine as long as they are getting, some clinical benefit.
Yep.
With their therapies. If there are no other questions, I think we can call it a day. I think we have finished very much on time. So thank you again for that wonderful overview of HFpEF for us. I think we will be ordering more echoes. I was getting text messages about this saying, hey, maybe we are missing all these patients with HFpEF, and I guess we can have a greater focus on the GDMT.
But then Swapnil will have to learn how to interpret those echoes and which of those numbers are we supposed to pay attention to, which I don't think we're competent to do.
Just use the H2FpEF score. That's all you need.
Okay, I'll look it up and we'll add it to our show notes. Thank you again, Dr. Khan. And for those who missed it, this will be available on our YouTube channel as soon as I can upload it. There will not be grand rounds next week because of AS and Kidney Week, and we'll resume again in 2 weeks' time. Thank you.
Awesome. Thank you so much. Have a great day.
Goodbye.